Hi, I'm Earl Silverman, editor-in-chief of the Journal of Rheumatology, and I hope everyone is doing well and staying healthy during the pandemic. Today, I'm pleased to be speaking to Dr. Catherine Bakewell from the Intermountain Healthcare Group, Salt Lake City, Dr. Sibel Aydin from the University of Ottawa, Dr. Veena Ranganath from the David Geffen School of Medicine, UCLA, California, Dr. Lihi, Eder, Women's College Hospital, University of Toronto, and Dr. Gurjit Kaeley from the University of Florida. These are the authors of a review article entitled Imaging Techniques, Options for the Diagnosis and Monitoring of Treatment of Enthesitis in Psoriatic Arthritis, which is now available as an open access article on the Journal of Rheumatology's website at jrheum.org. I want to thank you all for coming and to thank you for writing the review article and for agreeing to join me in discussing it. So I have a few questions to ask you, so I'll start. So my first thought was, who thought of writing this and why now?
Good morning. So I'll do my best to answer that. As far as whose idea it was definitely not one person's idea. This was absolutely a group effort. But if you were to ask the question, why this topic and why now, there are several points to consider. The first is that enthesitis is incredibly prevalent for patients with psoriatic arthritis. So it is estimated that up to 60 to 80% of patients with psoriatic arthritis will experience enthesitis at some point in their disease course. Traditionally, this was always assessed by clinical exam as well as conventional radiography. But with the emergence of advanced imaging techniques such as ultrasound, MRI, CT, as well as some molecular imaging techniques, we really have a much broader armamentarium for the earlier detection and also monitoring of treatment response for this condition. Further, second, enthesitis has been proposed as the seminal lesion in psoriatic arthritis. And this concept goes back as far as 1999, when Dennis McGonigal at Leeds put forward this idea that this was really the underlying or the seminal lesion, again, that pushes the rest of the disease forward or starts the cascade of events off. And this has been further supported by subsequent research from individuals such as Georg Schett out of Berlin and others. And in this, imaging really does play a key role in understanding the sequence of events and inflammation at the level of the joint capsule or the other entheses. Third, our technology has advanced incredibly over the last several years. And I can tell you that with this, our imaging techniques not only have better resolution, we're getting better images. We're able to see things that we just couldn't before. And I'll give you a personal example for me in fellowship. Learning musculoskeletal ultrasound specifically about 10, 11 years ago, the machine that I was working with left a lot to be desired. So we'll liken it perhaps to a standard definition TV, whereas now, a lot of us have the high definition or even 4K TVs in our home. That's what you might find in an everyday, rheumatology practice as far as level of machines. So there's been a big difference in the quality of images that we're able to get and what we're able to appreciate at the level of the enthesis. And last, I just want to say this is a really exciting time for research in this field. There is ongoing work by groups such as GRAPPA and OMERACT to develop scoring systems, both for the diagnosis as well as the monitoring of response to treatment of enthesitis. And so this is something where we've already got wonderful research that has been done, and there's going to be more done to validate these scoring systems for these diseases and these uses. So it was a real honor to get to work with my co-authors on this paper, and thank you, Dr. Silverman, so much for talking with us this morning.
Anyone want to add to that? Yeah, it was overwhelming to me, so good. So along the same lines, and sort of was hinted at by Dr. Bakewell, why is it so important to diagnose? Why is it important to diagnose enthesitis and psoriatic arthritis? And corollary, Do you think everybody has enthesitis in psoriatic arthritis, which may be subclinical, especially as Dr. Bakewell was saying, that it may be the seminal lesion? It may be the defining lesion of psoriatic arthritis. And then as a side, just a little thing that I can't help, we certainly don't appreciate that in JIA, in psoriatic arthritis, seen in JIA. And maybe that's our ignorance, or maybe it's a different disease, but we don't need to address that. Just the first question of the importance. Anyone want to address that?
Yes, thank you, Earl, for the question. So the importance of diagnosing enthesitis in patients with PSA is related to several key reasons. So first, as Catherine mentioned, enthesitis is a key pathophysiological lesion in patients with PSA and maybe the initial manifestation of the disease. As you mentioned, many of the patients have enthesitis even before the development of peripheral arthritis, and it can be quite challenging to diagnose only based on physical examinations. So if a patient with psoriasis presents with only enthesitis without peripheral synovitis, it can be quite challenging to diagnose, and this diagnosis may be missed and delayed because of that. So that's one of the key reasons why we need to diagnose it early. Secondly, it's also important to diagnose enthesitis in patients with established diagnosis of PSA, because there are some studies that show that enthesitis is a marker of severity in patients with established PSA. It's associated with reduced quality of life. So you can imagine if you have enthesitis in a weight-bearing joint, such as in the Achilles tendon, it can have a significant impact on their quality of life. And there is also some data that suggests that having enthesitis is associated with development of radiographic joint damage. So identifying it and treating it early is really a key factor in achieving a minimal disease activity or remission in patients with PSA. And finally, there is some data to suggest that there are differential response in terms of enthesitis with respect to different treatments. So identifying enthesitis in patients with PSA can guide treatment selection. We know that non-biologic DMARDs may work less well, or there is no data to suggest that they work at all in patients with enthesitis, unlike perhaps peripheral arthritis. And there is also some preliminary data from clinical trials that suggest that perhaps some of the classes of newer biologic agents may work differently for enthesitis compared to peripheral arthritis. So we certainly need more studies and more data, but these are the reasons why it's important to diagnose enthesitis in patients with PSA.
Any other comments before we move on? Okay. So in the article, you review the different imaging techniques for assessing enthesitis. Would you briefly outline the advantages and disadvantages of ultrasound versus MRI? And of course, we'll ignore plain radiographs because we know the insensitivity of that. Somebody want to address the issue, because really that's what it comes down to, beyond the convenience. Obviously, very few people have a point-of-care MRI machine. So.
Thank you, Dr. Silverman, for this question. I would say, ultrasound is fun. Our patients look forward to it. But kidding aside, I think the first, I want to make 3 points. I think the first is when you do an MRI, generally what's available now is a single site MRI, for example, doing an ankle. So you can look at the ankle, very fine detail, but you're just limited to that site. I do allow that there are some new protocols, whole body MRI protocols being established, and this is sort of borrowing from the oncology field where they've done, looking at bones predominantly to look for metastasis. The same protocol has been ported over to look for enthesitis, but this is really good for more large enthesias around the trunk. It's not really great for limbs. So I would say that's really not prime time. So the ultrasound is really great to go into the entheses that you're interested in, and predominantly they tend to be lower body, and then through the work with GRAPPA, we now know that we have to include some upper body entheses too. So you can go to several entheses in the same sitting very quickly, and it's very patient friendly. And most of the time when the rheumatologist is doing the scan, we're talking to the patient, and it's really a great patient-physician interaction, and our patients really appreciate that we are telling them what we're seeing and making sense of it as we go along. So I think, first of all, that's the greatest. And then just digging into some technical advantages, disadvantages, ultrasound actually gives you much more detail of the enthesis and the ultrastructure itself. So we can see the fibrous tendon, much better detail than MRI. The advantage MRI has is that it picks up edema or fluid very easily, and that's why it tends to be sensitive, but its level of resolution is not that great. And this is also one of the Achilles heel of ultrasound, is that we can't see beneath bone. So MRI can see beneath bone, and it can inform us of bone marrow edema, whereas ultrasound cannot. So usually if you're doing ultrasound, we usually marry that with a plain X-ray, and by doing these two things, we're able to get, not miss big lesions underneath the bone, but we cannot see bone marrow edema. I think the other issue is that we can see vascularity very easily without using any contrast material. So Doppler techniques are applied very easily, and we can see Doppler not only in the tendon, but in enthesis itself, and as well as the associated structures around the enthesis, such as bursitis. In MRI, there's a debate whether you'll be convinced that picking up edema constitutes inflammation. It may not. It may just be, for example, bone marrow edema may just be reactive because you've been out jogging and you came back and did an MRI. So that really more depends on giving IV gadolinium to prove that you have increased vascularity there. So I think that's also that advantage. So I think I would say MRI looks at great level of detail, but in a limited area, whereas ultrasound can go to many places, can look at the superficial structures in great detail. And lucky for us, most of the entheses we're interested in are superficial, close to the skin, and we are able to get great images. We're able to look at components which are inflammatory. So beyond Doppler, we can also look at structural changes that are potentially reversible, like hypercogenicity, thickening. And we can also look at things that are damage as we regard them, like calcification, small enthesophytes. And these structures you can see in MRI, but not as well. So I think, again, ultrasound gives you a much more detailed view of these nitty-gritty problems that occur in entheses. So I would contrast in that manner that to recap, we can go to many places, see better detail, but the Achilles heel is we cannot see bone marrow edema.
Anything further? Yeah. So I have a question along those lines. As you outlined, Dr. Kaeley, how long would the average ultrasound take, as you outlined it, approximately, in the hands of an experienced ultrasonographer who routinely does it?
So if we're just interested in enthesis, the scan is actually pretty quick, 20 to 25 minutes. I will tell you my personal experience. I get bogged down when I see pathology, and I get very interested in talking and trying to correlate it with the patient. And I will tell you that's what slows me down. It's not that doing the scan it's slow. It's just you become so enthralled in what you're seeing. You're seeing actual pathophysiology, and you're trying to make sense of it with the patient there and trying to correlate whether this is what's bothering them and how important it is to them. So I think that's what's for many of us who are really interested in this, that's what slows us down. But it's not the actual physically doing the ultrasound. It's pretty quick.
Okay, very good. So along those
And actually, Dr. Silverman, oh, I'm so sorry to interrupt. I just wanted to add one thing, which is I think too, I completely agree with Dr. Kaeley that 20, 25 minutes to do an in-depth exam, but I think many of us often also have an ultrasound on just in the exam room as we're seeing a patient. And I may spend a minute or 2 minutes just taking a quick look at a region sort of as an extension of the physical exam. And I think both, it's in that instance, you're not doing a full separate report and billing for it separately. You're just having a look and using it again as a stethoscope, if you would. So I think there's both are very appropriate uses of ultrasound in clinical practice. Again, forgive the interruption.
No, that's great. That's very helpful. Any other comments? For people who, speaking to the routine users. So I guess as somebody, I guess, still a dinosaur when it comes to ultrasound, mainly because I guess I don't see Jay anymore in my practice, and I'm old. So, and I was taught the physical examination is so important and tells all. So from my practical point, I understand the pathophysiology, and it's very important. I understand pathogenesis is very important, and I'm not playing that down in the least. I'm just saying in the routine care, not in a study, but in routine care, how important would be the 20-minute, 25-minute study, not the quick study that Dr. Bakewell was mentioning, in routinely monitoring a patient in your practices. So I guess my question too wants to answer it is, we now really believe in patient-measured outcomes. So if we use that, how much do you believe in following your patients daily? This adds to it. How often do you think it changes your therapy and alters their outcome?
Thank you very much, Dr. Silverman. I'll be happy to answer that question. So I wouldn't say that all patients need to be routinely assessed with a point-of-care ultrasound for enthesitis in every visit. Although the emerging data on subclinical enthesitis is very interesting and has the potential to change our practice in the near future for prediction, even at the stage of psoriasis with no joint symptoms, we don't have enough evidence to say that all patients need standard screening with the ultrasound today. I believe as of today, the main advantage of point-of-care ultrasound is whenever the rheumatologist is planning to modify the treatment on the basis of enthesitis symptoms or diagnose a patient with psoriatic arthritis, then ultrasound provided information would be very valuable to ensure that the pain is due to an inflammatory process and justifies increasing the immunosuppressive therapies and avoid unnecessary modifications or false diagnosis even. So the ultrasound adds an objective, visible angle to the physical assessment that is simply the detection of subjective pain. And the ultrasound certainly needs to be done before increasing or modifying the treatments, as you need to have a baseline assessment to observe the change over time. Having said that, the ultimate aim is the patient's well-being, and after modification or enhancement of the therapies, if the patients respond well clinically, I don't think there's a value to repeat the ultrasound just to observe the changes on imaging. So to summarize, I would suggest using the point-of-care ultrasound to understand if the pain on the enthesis is due to an inflammatory process and decide whether there needs to be a modification on immunosuppressive therapies, and for monitoring only if the patients do not respond to those therapy changes. With the upcoming exciting data, we may have new indications for enthesitis ultrasound in the near future for target prevention of psoriatic arthritis, so stay tuned. But I see the value for today as I just explained.
Thank you. Any further comments on this?
Yeah, I just want to amplify what Dr. Aydin has said. I think when their patients come in, they're not really asking about how their disease is doing. They're more worried about symptoms. And I think as clinicians, I think that's where we would really like some additional tools to figure out, is this actual enthesitis still present, or is this mechanical? and trying to differentiate between what's going on with the patient, so that you're appropriately increasing the therapy. And there's a similar corollary in rheumatoid arthritis. When you do the CDI, there's patient-physician discordance. I think for us at this point, that's the most valuable use of this technique. And I think going back to your treat to target question, the problem is we're still in the middle of trying to validate what the best set of entheses are. And this is with any imaging technique. And the reason for that is because there's a huge biomechanical confounding with these things. And even if you just look at the outcome measures available, amongst the clinical outcome measures, only the LEI tends to perform with any degree, showing good effect size, whereas all the others are all over the place. So I think time is not right now for a treat-to-target approach, especially with imaging. And again, with enthesitis, even in the clinical world, it's still a little puzzling which is the best instrument to use. We really don't know what the LEI is measuring, because when you do ultrasound in these patients, you don't really see enthesitis in the places that respond. So to go back to your question about treat-to-target, I think we still have a lot of work to go to prove that we can use ultrasound for treat-to-target. But I think in the clinic, I think ultrasound has a very valuable role to play to answer the questions that our patients present with.
I have a quick question for you for maybe some people in the audience. What does LEI stand for?
That's the Leeds enthesitis index. So just to stand back a little bit. So enthesitis clinically is measured by palpation of enthesis, so 4 kilograms per meter squared pressure. So your fingernail goes just pale, that sort of pressure. And so by history, we started with the Mander index, if you remember, which was a whole number, more than 60 sites we had to palpate. And then in ankylosing spondylitis world, we kind of whittled this down, and our Canadian colleagues came up with the Spark index, which was evidence-based developed. And then similarly, the Leeds group developed a Leeds enthesitis index, which was solely designed for psoriatic arthritis. So in clinical studies, generally, things that are used most commonly clinically are the Leeds enthesitis index, the Spark index, and then something called the Maastricht index, the MASIS. So, and the MASIS also is problematic because it's got a lot more axial sites than peripheral sites. And those tend not to really change much. And even if you add 1 or 2 peripheral sites like the plantar fascia, create a modified MASIS, it still doesn't perform as well. So I think there's a big need for imaging to come up with some sort of imaging outcome that can give you a much more unbiased view of what's happening at the enthesis, and to see what's responding. When you're palpating, the only answer you're getting is pain. You have no idea, is there still inflammation? Is my damage arrested? And are there any other associated structures like bursitis that are still active? So I think there's a huge need for imaging to answer those questions. And then I think with all these new biologic agents that we're getting, we're very, very interested. Are all the cytokine targeting behaving similarly at different targets in the tissue, and do they respond similarly in decreasing damage in the tissue in the long term? So I think the axial SPA world is a little bit ahead of us in thinking those questions. But I think when we look at peripheral enthesitis, these questions are also very interesting. I think we're very interested in applying imaging to ask those questions.
Thank you. Okay, any further comments on this?
Yeah, so I think to conclude, I would just say that we are living in an era of precision medicine. We have an increasing number of targeted synthetic and biologic DMARDs available to us as clinicians, and we know that early intervention leads to better outcomes. And specifically for psoriatic arthritis, this really was highlighted in 2014 by the paper Haroon et al. Wrote, showing that even a 6-month delay in diagnosis was associated with roughly 4 times the number of erosions, twice the level of subsequent disability, and even though rare, 10 times the risk of the most severe form of psoriatic arthritis known as arthritis mutilans. And so when we're talking about a disease like psoriatic arthritis that is by definition seronegative, there's no rheumatoid factor CCP, ANA to clue us into the presence of the disease. And in fact, our inflammatory markers may or may not be elevated even in active disease. It behooves us to look for things like imaging enthesitis that can serve as a biomarker, so a clue not only to the presence of disease, but can give us information about the activity of the disease. And you've just heard my colleague speak very eloquently at how there is a discordance. Imaging gives us objective inflammation. Clinically, it's you press and do you say ouch? And we know full well that central sensitization, fibromyalgia, this is very confounding and something that we face often in our clinical practice. And so to have objective information, this is inflammation, this is not, this is looking more like a spondyloarthropathy, this is looking more like a neurogenic cause, that's very helpful for us as clinicians. And so I think as our imaging modalities have advanced, we really have this capacity not only to detect the disease earlier, but to phenotype the disease, how active is it, what domains are involved, and to target our therapies. And the hope there, of course, is that we're going to have better patient outcomes. So to summarize, this paper was meant to be an overview of the state of the art of all different advanced imaging techniques for the detection and monitoring of enthesitis, and also give us a glimpse into some future research directions. And if we were to summarize, I think for us all in saying that I think the future is very bright for the use of these imaging modalities in our clinical management of psoriatic arthritis and enthesitis specifically.
Any other further comments? No? So I want to thank you and say I certainly learned a lot, and I think evolution has come. The dinosaur has joined the 21st century, and I believe that imaging is certainly very important in psoriatic arthritis, and there's such obvious advantages about ultrasound over other imaging modalities that I guess the good news is I don't have to learn it because I don't treat people with adults with psoriatic arthritis. But to those out there, I believe you'll think the same way I do after reading this excellent review article highlighting exactly what Dr. Bakewell said. So I want to thank you all for taking the time and providing this excellent conversation, which was very empowering to me and enlightening. And I'm sure it will be to people who read your article, and I encourage everybody to read the article. So please read the review article. Again, it's entitled Imaging Techniques, Options for Diagnosis and Monitoring of Treatment of Enthesitis in Psoriatic Arthritis by Drs. Bakewell, Aydin, Ranganath, Eder, and Kaeley, and it's available at www.jroom.org as an open access article. If anybody has any comments or questions, please message us at Twitter at jroom or email us at manuscripts@jroom.com. And I want to thank everybody for joining us, and I want to thank the authors for spending this time with us. And I just want everybody to please stay healthy and well in these times, and please observe your social distancing as dictated by your regional or national health authorities. Be well and take care, and thank you.
Thank you so much.
Thank you.